Hello and welcome back to the Parents and Mouse Breeders. I'm Tasha and today's episode is with Dr. Aoife. She's a dentist based between London and Kent, and her work effectively sits right at the intersection of tongue tie, early orthodontics, and breathing and airway health, which is what so many of you will actually be here for. Aoife was one of the first professionals who properly saw what I was seeing in my son. So we met in person a couple of years ago. I took my son to see her, and the assessment she did was honestly the first time I felt validated rather than brushed off. After a long run of being told that all these things were sort of normal or nothing really to worry about, she helped me see that they actually were. So, in our conversation, we go right back to day one, looking at the early signs that parents can look out for. We talk about good feeding. So instead of, just focusing on the position, what mechanics we need to look for when feeding your child as well, how mouth breathing affects growth, sleep, and development overall, and ultimately why teeth and orthodontics are often downstream from airway issues. They're not separate to them. So, just a quick note here. Obviously, we're sharing information, not medical advice. If anything here does ring a bell for your child, just use it as a prompt to ask better questions and throw the rest away. I know we're utterly overwhelmed a lot of the time with information online, and I don't want to add to that noise, but I do hope that you find this information valuable. All right, then let's get into it. Dr. Aoife, thank you very much for being here today.
Thanks, Sasha, for having me.
Thank you. So, you're a dentist based in London and Kent. So, for the parents that are listening, can you tell us a bit more about what it is you do?
So I am a general dentist. I'm working across two practices in central London. I predominantly, I would say my practice is maybe 70% pediatrics. I mainly treat tongue tie and early interceptive orthodontics. I also do a little bit of adult orthodontics, some TMD treatments, and I also look at things from a myofunctional approach. So I am a trained myofunctional therapist. It's not a service that I offer, but I do assess my patients for myofunctional disorders, which I think ties in really nicely because when we're looking at mouth breathing, if that is a significant myofunctional disorder, we should be breathing through our nose. And by looking at patients through that lens, I think we can frequently help them along their health journey.
Well, for some context for those listening, we've actually met in person, I should add, because I came up to see you, oh gosh, it would be over 2 years ago now.
Years ago,
Yeah,
yeah, I think
wow,
so.
with my son. And you did a really thorough assessment of him. And I think I said to you at the time, you really validated me because I'd been going to see lots of different professionals, obviously within the context of the NHS, and being fobbed off all the time, told that things like snoring were normal. He was having sleep apnea episodes, and I was told that was normal. I was also told that he didn't have tongue tie. And so I was trying to bang on all of these doors, and everybody was telling me that I was nuts. And I knew intrinsically there was something up. And then I came across you because of somebody that I follow on Instagram. And she had had a tongue release in like her 40s. And she had put something on there. I was like, oh my gosh, like I need to speak to you. And then I brought my son to see you, and you gave such a thorough report on everything that you found. And I don't know if you remember, but you gave him some temporary, what you called hot cross buns on the back teeth.
Yeah, some
And
bite risers. Yeah,
yes, and I know you said at the time they're not sort of a permanent solution, but for the time that they did last, they really did make a difference.
amazing.
Yeah, and so I was, really impressed with how thorough the appointment with you, and it gave
Um,
me
Good to hear.
confidence as a parent, that we were on the right track and that there were issues that needed looking at, and we're still on that journey. But you were the first sort of professional that we saw outside of the NHS that gave us the insight that we needed.
Oh, amazing.
Yeah,
Oh,
so thank you for that. So, with
that's
that
so
in
nice.
mind, how can parents recognize early signs and figure out that intervention might be helpful for them?
Well, let's start at the day one. So, there is some research to say that if a child has their mouth open, it's more likely that they will be tongue tied, which is really interesting. So if the child is resting with the mouth open rather than closed in their early days, then there may be something to look at. Obviously, then we're looking at how they feed. So how the child will latch and how comfortable that is, whether there's tension, whether there's good rhythmic jaw movement, whether there's good rhythmic swallowing, suck, swallow, breathe, and how that reflex works and functions. So I would say it's really important if you decide to breastfeed that you have somebody working with you that really understands breastfeeding mechanics, not just position. Position is really important too, but the mechanics of how that baby is taking the milk is really important. So there are lots of lactation consultants that IBCLCs and the rest. If you, most places within a driving distance, you'll be able to visit La Leche League. So there's really amazing support there. I've done that with both of my babies. But hiring a really good lactation consultant if it's possible is always a good thing to do. Then that's what we're looking at trying to get things going from the very beginning. Other things to look out for in the babies would be like reflux if they're very refluxy. Why is that? Is it because of an oral issue or is there something like an allergy? The thing that we tend to see with reflux is that we're going to have more congestion in the nasal passages because of some of that acid going up there. So again, that's something that may end up leading them to becoming a mouth breather. So ultimately, our babies should have their mouth closed and they should be breathing through the nose. We can support them with that too by using nasal sprays or just a little bit of saline rinse. Both of my babies had picked up terrible little colds at 3-4 weeks of age, and we were just popping little saline drops in there, and I was very mindful to make sure that they would continue to nasal breathe. But that's a little nugget that you don't get told in your NCT class.
No, you definitely don't.
So, really important to support that the younger age, because actually so much of the head growth, 60% of the head growth is done by age 1. What?
Gee whiz, yeah.
So, and 95% done by age 10. So it's such a fundamental time, and promoting nasal breathing is really, really important. The other thing we want to support is tongue to the roof of the mouth. So look at, in an ideal world, we want to breastfeed exclusively for the first 6 months, but that's not always possible. Look, I couldn't do with one of mine. I had to go back to work, but the exclusive act on the breast means that that tongue to palate connection kind of continues when the mechanics are correct, but not when we're not latching properly. So again, getting that support from the beginning is really quite important.
Can I
Other things,
interject there? Just,
of course,
just to add my experience, because all of my children have been exclusively breastfed, and yet I've had these issues with them. And I think you've hit on something there, that third time around I'm breastfeeding as we speak, and I didn't know that. I didn't know that actually the function, position's one thing, but actually is it functionally working as it should? Maybe, reveals to me why I had such issues with both boys.
they were both child, right?
Yes,
So
yeah.
they managed to get the milk, they managed to thrive, they managed to get their weight up, but it's not just about weight.
No.
Actually, sometimes infants who are tied, for example, or whose mechanics aren't correct, they kind of shoot up in the numbers quite quickly.
Mm-hmm.
Because they're kind of compensating for it, or your milk supply will compensate, but then maybe at around 3 months that can start to change, or we can, so tracking weight along the way is helpful. Also, if you have a lactation consultant, they will do like a weighted feed, so you can just monitor and see what the baby's taking in as they're growing, to see if that's appropriate for them and their weight gain. And then the other thing is sleep. So how are they sleeping? Are they managing to connect those hours properly? Is your baby awake every 30 to 40 minutes, or every 33 minutes, or every 39 minutes? That is a sign of something very uncomfortable for that baby. In most cases, I would say it's probably reflux, but there can be other issues, and like, seeking the proper support for that is essential. I'm not saying I'm the right support. I'm not a baby infant feeding specialist.
Mm-hmm.
The likes of La Leche League or your local baby centre, really good place to start. But if you feel like you're being told maybe you're fine, all asking further questions or seeking deeper advice. Then after sleep, we're looking at how the teeth are coming through. So if there's spacing, ideally we should see quite a bit of space between the maybe teeth. That we should say that you'd be able to fit a penny between all the teeth. If you're not, then we know the jaws maybe aren't developing as big or as well as they should. There will be some genetic component. Your children are going to look like you, but there's a huge epigenetic factor in jaw development. For example, stick a dummy in and you get an open bite. Stick a thumb in and you get a lateral open bite. Our muscles and whatever we put in the way of our teeth will act like their best orthodontist. So if we send things in the correct way, if we're chewing food correctly, if we're using our tongue up in the roof of the mouth, there's going to be space for it as we develop those jaws. They're so soft, beautifully so, because it means that if we do need to make an intervention, it's quite easy to do when they're young. Obviously, there's patient management issues, and that's a whole other ball game. But when the jaws are growing, it's possible to manipulate. And I have a diploma in early interceptive orthodontics, so it's something I do quite a bit of with great success. But the jaws are malleable and movable. But there is a genetic component, but there's a huge epigenetic factor. Like if our mouths are open, we're going to get this backward growth trajectory, a longer face. They'll look like me because I'm outbred for breathed for most of my childhood. I
Yeah,
expect.
me too. I had braces then when I had the whole shebang. I had my tonsils removed, my adenoids removed when I was
Wow.
young, and then I ended up having braces when I was a teenager. And my teeth haven't gone back to as bad as they were, but they never sort of stayed in that repaired state.
Okay.
Yeah, partly because I wasn't disciplined with the retainer afterwards. Yeah, so me and my brother, we both had very similar, really, really goofy overhangs, but he was so disciplined with his retainer, so his teeth are like yours, perfectly straight, you know. So yeah, I look back and I'm like, oh my gosh, like I know my son is exactly what I was as a child. So I'm trying to repair myself through him, you know. It's a bit of self-healing as well. So I think you've highlighted that it's never too soon to get started looking at these signs and thinking.
No, and it's so interesting. There are actually guys in America doing in the utero studies. If you are like preconception, like getting your gut in as best condition as possible, getting as much sunlight as you can, getting off the screens, supporting your genes. Like you can have like variations in your genes, we all do. But if you know about them, if you really want to dive deep, you could look at genetic testing and then supporting that gene type with an appropriate diet. Often it's like the Mediterranean diet, but keeping sugars to a minimum. There are actually things you can do pre-conception that will make a huge impact on your child, including their craniofacial development. If you got loads of vitamin D, K2, zinc, magnesium, all the good stuff hanging around, ready to build a baby, then it's going to build a robust baby, right? We have different cells that create different parts of the face, and within that you have the tongue, and the tongue is supposed to separate from the jaw at that early stage. And if that doesn't happen, you get that midline attachment, which is considered the tongue tie. That's happening pre-10 weeks. So these are all, in theory, they're all manageable pre-conception and during that time. It's again, gut health, really, really priority. I would say there's a lot of probably blue light damage because our sleep is not like where it should be. Getting the sunlight, getting like a really as nutritious diet as we can, organic food, all those things. But in reality, like in England, almost impossible to achieve.
Well, I listen to Andrew Huberman quite a lot, the Huberman Lab. And one of the things he always talks about is morning sunlight. And his thing is no matter where you are in the world, you're still getting those UV rays and you still need to be out in it. It just means you need to be out longer. So I'm like, well,
there's not many UV rays here today.
No, I'm like, seriously, come and live here in the middle of winter and tell me that theory works. And also, I don't want to stand out in the hammering down rain. If it was sunny, I'd be out there all the time.
If you had time, also, this is an issue. Like, because once you start having more kids, you're like, well, who's going to mind that kid while I stand in my bare feet for 10 minutes
exactly.
in the rain?
Yeah, it's a total different ball game when you're a mum trying to juggle a load of kids.
But we have to be kind and gentle to ourselves. Like, I'm a mother too. This is not an easy road. If you got a child who's got bad breathing issues, it's not easy. And it's about being compassionate, about understanding, about like not taking blame. This is an issue that like I see moms like every day crying in the consult room, and I'm like, listen, this is not for you to feel you've done something wrong by your child, because you're here and you're doing so much by them. We're here together and we're going to try to troubleshoot this, and we're going to try to get things as good as we can. And they're growing, so they've got loads of potential for change. But compassion, because our kids get that from us. If we can be compassionate to ourselves, they can be compassionate to themselves. They learn that. Feeling this big guilty whatever, I don't think it serves us as mothers. It's just a side point.
Well, one of the things I think as well, but you leave hospital with your new baby and you're often given this bounty bag with promos for things in it. And there should be a pamphlet about early signs of airway dysfunction or something of that nature, because, as you say, they're even looking at it in utero now. All we can do as parents is arm ourselves with the information that's out there. What role does the airway play in facial growth, sleep, and overall development?
So our bodies will protect our breathing capacity as its highest priority. Okay. There is interesting studies, again, early studies, but the rate of SIDS is increased in patients with lip ties is increased. Now, I think the reason that they chose to lip tie is because commonly if one has a lip tie, they have a tongue tie. So my understanding would be it wouldn't be the lip tie that has caused the SIDS. However, if the tongue isn't able to have great mechanics, then that can affect the airway. Again, it's like this is early research, and it's not to say every kid with a tongue tie lip tie is obviously going to have a SIDS situation, because it's very, very rare. But that is an interesting study for people to ponder upon and try to figure out what information we can more clearly take away from that. It's a very sad thing to look at. In other situations, when SIDS is out of the equation, which is in 99.9% of cases, our body will adapt around the airway. So the airway is a collection of muscles that supports our breathing mechanics, and we will absolutely prioritize breath over every other nutrient. So getting that oxygen and carbon dioxide in the correct form is going to be our priority. So it means that in the extremes of having, say, sleep apnea, we will essentially stop breathing, and then our body will kick into action and we'll breathe again. And that's what happens in sleep apnea. So normally you stop and breathing for around 10 seconds, sometimes a bit longer, and then we go boom. And what that apneic event will do is cause issues in the heart, issues in the brain, issues in our vessels throughout our body. You'll see hypertension, you'll see, higher risk of dementia, you'll see poorer immune system, you'll see increased risk of diabetes, you'll see all these things because our body is in a stress mode, in severe stress mode, but it comes back. Okay, so that's the kind of end stage result of not breathing. Let's take it back now to what happens when that airway is compromised. So supposing there are tonsils in the way, often what will happen is if the tonsils are really large, the jaw will come forward. Or if the adenoids are really large, the mouth will open. So we will compensate around that to make sure that we can get the air in. At nighttime, what will happen is, okay, well, everything is not great in this position, so I'm going to lift my chin, open that space, and make sure that we can get that breath in. So all of those things would be, to be considered. If our posture isn't great, if we're putting our head forward, these are things we will do to compensate to get that breath in. And that breath is the priority for our body. We can deal without food, we can deal without water for a day or two, I guess, but we won't survive longer than, I think, 5 minutes. You can you can go, but I think you would need to be resuscitated. But I think 5 minutes you can go without a breath.
I know a lot of us parents are told when we go to see an ENT, for example, and I was told this by two separate ENTs, that my son would likely grow out of it. the reality of it is they're not growing out of it. They're learning to adapt to it, and their
Growing
bodies.
around it,
Yeah, yeah,
like
okay,
naturally growing around it.
yeah,
So
yeah.
head will go forward,
Mhm,
mouth will open, and yeah, and we'll grow around it. So our form will follow our function, and the function will dictate the form. So yeah, I mean, in some cases, tonsils will get really large for a short period, and then they will just shrink back down.
mhm,
You know, sometimes it's an inflammatory response to an allergen,
mhm,
a pet, a mold situation, some sort of weird food that got exposed once in a pub. You
mhm.
know, there's no, this is the way it
Yeah.
is, and that's the way it is.
Mm,
And I think that's where we're struggling with like producing decent, solid evidence to
mhm,
say this is that. And also because it's multifactorial. That
mm,
you've had a dentist, you've had an ENT, you've had a myofunctional therapist, you've had a physiotherapist, an osteopath, a chiropractor, you know, an occupational therapist, a feeding specialist, you know, all those people are trying to come together to, you know, there is no research to say, this is this, and this is how we do
if
it.
only.
Um,
Yeah.
you know, and I don't think that research is ever going to come along because one, who's got time to do that without the decent funding?
Yeah.
Um,
That's it.
you know, and I don't think there is much funding for something like breathing.
Mhm.
It's there's not, you know, there's not huge amounts of money to be made from a drug that can change everything.
Yeah. Yeah.
Sadly, there, you know, if we could fix this with a drug, obviously we would.
Mhm.
But I don't think it's a bit more nuanced than that, isn't it?
From a dental perspective, because I didn't know this, you know, until I started looking into it, and I wanted you to add some context for people listening. You know,
Sure.
orthodontic concerns, you know,
Yeah.
I always thought they were just separate, you know, it was just a separate thing. But actually, they are potentially or more than likely downstream from airway symptoms. So, with crooked or crowded teeth, can you explain how that's part of this wider airway issue?
So we would say that, like, again, like there is a genetic component to the
Mm-hmm.
position of our teeth. Our faces will be similar to our parents.
Yeah.
However, there is also an epigenetic component. So just like I mentioned, if there's a dummy in, it's going to make things go one way. If the tongue is lisping in the one direction, it's going to make things go another way. Whatever we put between our teeth and however we function, our jaws will make an impact on how things are developing. Frequently, we call it class two malocclusion. So either the front teeth are further ahead and the back teeth are here, so that recessed lower jaw, or and that can start from quite young because the jaw hasn't been able to function properly due to a poor posture of feeding at the very beginning. Let me revert back. So this is an overjet. So the front teeth are a little bit further forward. You mentioned the goofiness.
Mm-hmm.
So that's an overjet. An overbite is when the teeth are like this. So that lower jaw is trapped behind that top jaw. Often it can be from an overgrowth of the top jaw. So we almost see like a downward when the tongue is not doing this peristaltic movement, the tongue can start to kind of hit here, and that causes this excess of that jawbone here. This teeth come backwards and these teeth get stuck behind. Those are the two most common presentations. The other thing we will see earlier on is this happening. So an underbite
Mm-hmm.
or a class three malocclusion. And those are all kind of earlier signs. The other thing we're looking at is position of the mandible, the lower jaw in regard to that, the up jaw. So if we see that the lower jaw is heading off to the side, we want to look at the teeth and check that there's a straight line
Mm-hmm.
between the midline. You could almost floss from the top all the way to the bottom, and you don't have to go off the side to floss. That midline is quite important for facial symmetry. And then the other thing is a crossbite. So crossbite is when that top jaw is narrower than the lower jaw. Again, we would think, well, the tongue hasn't really been living up there. It's been down low and creating a beautiful lower jaw, but that top jaw is then quite narrow. So that's when we're thinking, and this word expansion comes in a lot. People talk about expansion, expansion, expansion. So that's where we would expand that upper jaw outwards. The issue that a lot of us interventionists would say is a problem is that people talk about expansion, expansion, but we don't necessarily talk about this AP development, this forward growth. We must consider both. when we're looking at the development of that maxilla, because we want it to be fully developed in 3D rather than in just a sideways direction, if that makes sense.
That's a really good segue, actually, because my next question for you was to talk about expansion. So I've seen lots of media coverage recently framing expansion treatments as more trends. You know, there's this TikTok movement around mewing and all this kind of stuff. What's sort of missing from that narrative? You've just touched on it there, that it's not just about expansion.
Yeah,
It's
so people
also,
come in all the time asking me for expansion.
do they?
Um, all the time, yeah. And the trouble is, like, when you get to a certain age, the jaws kind of are set where they're set. And
Mhm.
this is where, like, extractions are often required, in a sense that, like, we need to keep the teeth within the bone. We can't just expand, we can't just move the teeth out of the bone. We need there to be bone support. So if a grown adult goes and says, I want straight teeth, an orthodontist will often say, well, I need to take 4 teeth out, because they're trying to keep the teeth within the bone, which is completely an important thing to do. But there are other ways of doing that. Like, in an adult, you can do surgical expansion. So you can put screws in the palate, split the palate, and open things up so that the teeth stay in the bone. Because we must keep the teeth in the bone. There's no point in having teeth out here if they're literally out here in my hands, because
Yeah,
they got
yeah.
loose, because we just pushed them out of their bony envelope. So but in a growing child, we can develop that a whole lot more safely, because
Okay.
the bones are a lot softer, and they're willing to move to where we need them, and want them to go. But we're not just looking at this. We need to think about this forward growth as well. And the earlier we can see the child, the better, because what we're trying to do is get the tongue up there, pushing that part forward. So a really nice appliance in a younger kid is like an ALF appliance, which is just a very gentle, soft, almost soft one. It's not soft, it's obviously hard, but
Yeah.
a very gentle, soft wire, if you will, that's placed in the palate. And the idea behind it is that it kind of encourages the tongue to get up. We
Mhm.
don't necessarily push the teeth, we just touch the teeth. And by touching the teeth, it's supposed to give them this proprioception that they go, "Oh, okay, I'll just go over there."
Yeah.
Just a gentle kind of, rather than pushing, where it's kind of a very gentle, almost like it's called like an osteopathic appliance, because it's that gentle. But really what it's doing is getting the tongue functioning better, and you get that forward and side growth. We also frequently will use like a an expander alongside like a face mask. So a lot of parents go when
Yeah.
we talk about a face mask, but it's actually like a reverse pull. So we're using elastics to bring this forward growth, and that works really well as well. We see beautiful change with that. Ultimately, just to try to drive that maxillary growth to its growth potential. We would never make someone look like a bird.
No.
It will stop
Yeah.
where it won't kind of continue. Again, you can push teeth out of the bone, so we need to always be very, very gentle with our movements.
Mhm.
Um, but yeah, I would say to parents, if they are listening, ensuring that whoever you see, like, understands the possibilities of what's achievable within the. I would say don't go expecting that someone can just do this magical expansion. Expansion is not magical. It needs to be, biology needs to be respected. But earlier treatment can mean that what's possible is greater. Does that make sense?
Yeah, definitely. And I think effectively, as I've received what you've said there as well, is that it's individual for each child. Naturally, you've got
100%.
the genetics playing a part, the epigenetics. You've then got, you know, their access, whether it's to what they can afford to do privately and all that kind of thing. So with sort of through my experience, you know, I've gone down the route of trying everything, all the alternative stuff, so that I could prevent surgery for my child. And I know a lot
Yeah,
of the parents that I speak to, they're trying to prevent that as well. I
sure.
listen to the likes of Barbara O'Neill, as I know you've met with her before. I went to see her last year. And she's very much from the, you know, removing all of the allergens and then, you know, sort of taping up the mouth kind of thing, and not to have the surgery. all this stuff. But I found myself in a place where it was like the last option. I was
I
trying
mean, I definitely wouldn't be encouraging somebody who's got enlarged adenoid or tonsils to
to,
tape their
yeah,
mouth.
yeah,
I think
yeah,
that's very
yeah.
unsafe, and I need to definitely say that.
Yeah,
Uh,
what I will
no.
say, because I don't think I gave a fair relay of what she said. She was saying remove all the allergens, which will
Mhm.
reduce the inflammation, and then
Yeah,
you can begin things like mouth taping during the day, like 5 minutes at a time, and then build it from there. But either way, that didn't work for us. Whatever it was that, whatever it is that triggers my son, I just still haven't got to the bottom of it. And so there's lots of us out there that don't want to go through surgery, but so there's some parents that are just gung ho with that and they won't move forward with it, or parents like myself who are on the other side of surgery now, and we're seeing some improvements.
good.
Some parents say to me, everything was amazing, and then sort of a month later, all the issues came back. I'm
This is, yeah.
finding myself in this middle ground where he sleeps quieter, he still
Mhm.
snores, but it's not as dramatic.
Okay,
He is unfortunately still having apnea episodes, but they are nowhere near as severe. I would say 80%
good.
improved.
Good.
Um, so my next route is looking at what next treatments I want to go to, because I understand that this isn't just a one-stop shop. You can't just go to one professional and expect sort of a solution.
Yeah.
So what does a genuinely sort of multidisciplinary approach look like in practice? So for us parents to clarify sort of who should be involved and when, and
Sure.
then from a dental perspective, when you would look to be involved with people that have these sort of wider airway issues.
Sure. So there's a really eminent orthodontist who has been involved in this space for a very long time, and he is currently sending his research, hopefully for publication, but he shared it with some of us, and he said that looking at things like a monotherapy, that they're from tonsil and adenoids to treat the respiratory disturbance index, so to treat a form of sleep disorder breathing, they were getting 40% like resolution. I don't know what his like cutoff was, but it certainly wouldn't have been zero.
Mm-hmm.
And then they were doing also a different cohort, same number of patients with rapid maxillary expansion, and they got almost 50% of this resolution. So what he said as his like final take home was that neither of these solutions by themselves are going to get you to zero. So what they're now looking at is a multidisciplinary approach with myofunctional therapy, because the airway, as I mentioned in the very beginning, is a collection of muscles.
Mm-hmm.
So we need to retrain that. You need to get us breathing through the nose. We need the tongue to be correct position. We need there's space to be for the tongue to be in the roof of the mouth, and we need no big, large inflamed tissues in the way. And
Mm-hmm.
if we can get all of those right, hopefully, this is
Yeah.
what we're hoping to find out from this research,
Mm-hmm.
that we shall start to see those numbers reduce further. At the moment, that's kind of what we've got to deal with. But we aren't exploring your under Huberman type of things, like
Mm.
as the child being outside, have they got enough vitamin D? Are they, exposed to blue light? Because we know these things also have an effect on growth. And we are just at the very, very beginning of understanding all of that. So I think we will probably see the results of that to really, truly believe that the results of that will be really promising and that will support this approach. But like the environments we live in are not set up for health. And if we're all spending hours on this all day long, look at your screen time from yesterday. Mine is probably like, including work, I'd say I was on a screen for 9 hours in the day,
Yeah.
at
Yeah.
least.
Yeah.
And that has an impact on our breathing
Everything.
mechanics. It stresses
Yeah.
us out.
Mm-hmm.
It has so many different like impacts. So I think that research will be fascinating,
Mm-hmm.
and I think it will give us a framework. But we do need to think about how we are supporting our general well-being
Mm-hmm.
and how we regulate ourselves for our children to regulate themselves, because
Yeah.
they will learn to breathe through us, particularly as babies, when we breathe, short, shallow breaths that are slow, then that's all going to teach them how to breathe,
Yeah.
again during pregnancy when we do It's there's so many nuances, and I don't
Yeah.
think we have answers, and I don't think we're ever going to get true answers.
No.
So I don't know if that's answered your question
It
at
did.
all.
It did. No, it did, definitely. I think really what you're speaking to is this is complex. It is multidisciplinary. And in a way, you know, for parents like myself, that's liberating to hear because much like you mentioned earlier, parents coming in, sometimes they feel as though they've missed a trick or they're not identifying things early enough. It sort of permits us to say, look, we are in the context of the modern world dealing with so many different environmental factors that contribute to things like the airway. And it isn't just this one solve of, say, having your tonsils and adenoids removed and expecting everything to be better. That actually we need to be looking at it through all these different lenses. And then, of course, the backdrop of that is going to be different for every child. You know, we are all individual, you know, and
Yeah.
you know, that ties into, I think, as well, what I try to tell people, because I have people messaging me all the time and I feel a sort of sense of responsibility. And I try and make it clear, look, I'm just coming from a parent perspective where I have no idea what I'm doing. I'm trying to figure this out as I go. And I'm still figuring out what's the best for my son. But I also say to them, trying to do this within the NHS alone, you can't expect that the NHS is going to give you the answers. So how would you sort of say that parents need to think about private care in this space?
I think we need to look at things from very much from a multifactorial approach, supporting as healthy a body as possible. Like I don't know if I mentioned in all those people that would be helpful on the team, nutrition. So this is it's a really important piece. As quality food as you can afford, as varied food as you can get your hands on, as fresh food as is possible, and as minimally processed. Those are all going to be things that are really going to support health. Trying to support good sleep by doing all the sleep hygiene things, trying to support as clean an environment at home as is possible. Those are all things we can absolutely do without really needing someone else's support, or absolutely hire the right people, like a really good nutritionist to support the family. With regards to, if the tonsils are very enlarged, then like that area is the area of the ENT, and if they're telling you those tonsils are so enlarged, really they need to go, then get on that waiting list, and don't rule it out, and in the meantime work on all the other things.
Mm-hmm.
There is good early evidence to say rapid maxillary expansion is a very good tool, and I'm seeing some really nice changes in some patients. But if their tonsils are grade 4 tonsils, I'm going to be saying you probably need to deal with that as well. With regards to the breathing, like myofunctional therapy and breathwork training, I think is really, really important. But again, the myofunctional therapist is not going to be able to breathe around grade 4 tonsils and adenoids.
Mm-hmm.
So, it's I think you have to look at it from a multidisciplinary approach. Some people will get fixated on saying, "Oh, well, I just have to deal with a tongue tie," and it's like we can't get the tongue to the roof of the mouth if their tonsils are so enlarged, their adenoids are. So I guess getting somebody to take a view on the position of where the patient is at, and then
Mm-hmm.
trying to link together the specialities as best as possible to to support as good growth as can be achieved, but also, like, as a parent, just doing it all with compassion the whole way through, understanding and believing in yourself that that you're doing the best for your kids, because you always are. I do feel like in a lot of cases, like, there's just a really, yeah, moms carry this like weight of responsibility,
Mm-hmm.
um and that just it's really heartbreaking.
Yeah, yeah, I totally agree. I mean, I know I always feel like I'm dropping balls on a day-to-day basis. I think that comes hand in hand with motherhood. And then when it's something like the airway and you're aware of all the downstream effects of not getting this sort of seen to, there's that layer of real pressure. There's real world results if I don't crack this code. And, you know, I suppose I want to say to those parents listening as well, I was so adamant against surgery. I'm like it with everything. I'm totally against screen time for the kids. They don't have any processed food. You know, I'm really gung-ho on all those things. But now, third child in, that sort of strict, you know, way of being has to be flexible, because there are times where you just need to forgive yourself for being human. And so, yeah, I definitely second that there. You know, we need to look at the reality is the fact that we're even looking at this and reading about it and considering it means that we care about our child and we're trying to get the best results. And so we're better off on that side of things than not knowing at all. But we also don't want to drive ourselves mad, you know, because you and I, as we said from the outset, these things weren't spotted in us as kids, and we're doing all right. You know, we're here. But
Absolutely. I would also add, though, our food quality, our air quality, the level of plastics in our system is
yeah.
it is significantly different.
Mm-hmm.
The blue light exposure is
Mm-hmm.
significantly different. So I do feel like we need to potentially be a bit more crunchy
Mm-hmm.
than than our parents needed to be.
Yeah. Well, this is why I
With the
think.
greatest respect to my parents, they did
Yeah.
a great job with all of us, you know.
Yeah. Yeah.
But you know,
Oh,
I think there's a lot of toxins everywhere, more than there was when we were small. Yeah.
and this is why I think there's a lot of sort of our millennial generation that butt heads with the older generation, where they think we're a bit over the top. And, you know, I say, like, particularly to my in-laws, this is a different world. Like, everything we have to think about now is way different to when we were younger. And so, you know, I second that as well. Okay, so everything we've discussed today really is highlighting the importance of early intervention as far as I see it. I really appreciate your time, and you know, obviously going through this myself as a parent, you've been really invaluable, and following you online as well. For those parents listening, where can they find out more about you, and can you signpost them to some of your work?
So my website is draoifestack.com, spelled Aofe. My Instagram is Dr. spelled DOCTOR _Aoife, AOIFE. Airway School, if you were a professional and wanted to kind of understand a little bit more about becoming involved in a multidisciplinary approach to airway health. That's airwayschool.co.uk. I'm pretty responsive. If people do DM me, I will typically reply. I have you can kind of book in a chat with me if that's something that was needed online before you would travel. Or I treat patients in two practices in central London at Optimal Dental Health and at NDU. So yeah, it's
Okay.
always an honor when somebody reaches out. It really is. I feel like for someone to want me to care for their child is it's just such an honor. Yeah, if people have questions, then I'd be happy to help if I can, or signpost them to someone who hopefully can.
Okay, awesome. And I can say that you were awesome with my son, who was very hyperactive when we came to see you, and you've dealt with him
Oh,
really
that
well.
is so
So,
sweet.
yes, thank you. I'll put all the links in the description anyway. So, thank you so much for your
You're very
time
kind.
today.
All right,
Thank you.
amazing.
Bye-bye.
Thank you.
Bye.
Bye.
So that was Dr. Aoife. I know this stuff can be a lot, especially, you know, if you're in the thick of it and probably sleep deprived as well and trying to work out what's normal and what isn't. I'm right there with you. If this episode gave you just even one useful takeaway, then, you know, that's a win. You know, so I'll put all of Aoife's links in the description. Her Instagram, she's on mainly, and she also runs the Airway School as well. So I'll put that in the description, and you can have a listen to her stuff. And if you're a parent listening, thinking, you know, what do I do next? There's a free guide you can download called 10 Signs Your Child is a Mouse Breather. That's just really to try and help you identify what some of the signs are and talk you through some of the initial steps you can take. There's also another guide called the Mouth Breathing Solution, which is a parent's guide to the multidisciplinary approach. So for those parents out there that already have identified that their child's a mouse breather and have easily identifiable airway issues, this is the guide for you, because it will talk you through sort of all the professionals that you might be able to turn to help your child. So I just want you to, spot patterns and feel more confident really in taking the next steps. They're both free, so take them both. If you found this helpful, please share it with another parent who's stuck in the same loop. And obviously, if you can leave a review, that's awesome. It could really help this podcast reach the people who need it. I've got 1 review so far, and I'm very proud of it. So any more added to that, I'll just be buzzing. All right, then. Thanks so much for listening, and I will speak to you in the next episode.